Hey everyone, I get to introduce Dan Fein. Dr. Fein is coming to us from Montefiore Einstein in the Bronx. I've had the privilege of working closely with Dan on some of our research, and I've had the opportunity to see his ICU. He's the director of the ICU at Montefiore Wakefield, and he's also the site PI for three of the sites that enrolled into the PREOXI trial. And having been to his ICU, I've been really impressed with the ability of his leadership and the nurses to all work together in improving the care within their ICU. And so really interested to see how they've incorporated the results from this PREOXI trial. So Dan, take it away.
Thanks so much, Tom. Thanks for that very kind introduction. It's really a privilege to be talking to you guys today. So thank you for having me. And feel free to interject at any time if you guys have any further questions or comments about what I'm going to talk about. So the title of my talk is Application of the PREOXI Trial Results in a Learning Health System to Improve Outcomes for Patients Undergoing Emergency Tracheal Intubation. So what I'm going to try and do today is tell you guys a little bit about the background for why the PREOXI trial was conducted. I will try to give you guys a front row seat into what it was like during the PREOXI trial execution. I'll tell you guys a little bit about the results and the context of the results. And most importantly, I'll talk to you guys about the concept of a learning health system and how I think this PREOXI trial publication and then implementation is a really interesting test case for how we can think about a learning health system in the context of critical care medicine. So first, I'll start with a case. A 45-year-old morbidly obese man is admitted for streptococcal pneumonia. Initially, saturation is okay on a nasal cannula, and then there's subsequent deterioration. The respiratory rate increases, patient becomes tachycardic, and there's respiratory distress noted clinically, and you decide to proceed with intubation. You give the patient a non-rebreather mask, you crank it up all the way, and you give a preoxygenation for 5 minutes. And oxygen saturation goes up appropriately, so you're comfortable administering the sedatives and muscle relaxants for intubation. You successfully place the endotracheal tube the first time. Oh, they're not advancing. Hold on. Okay, I'm going to try sharing again. You guys see this case, the slide with the case on it? Looks like it, right?
Yeah, that should work.
Okay, gotcha. Okay, so you intubate the patient. The actual tube placement goes well, but the patient desaturates. There's subsequent normalization of vital signs once you bag the patient. So you're happy that you intubated the patient, but you worried what the long-term impact is of that drop in oxygen saturation. And you wonder if you could have done something differently. So I have certainly been in this situation more times than I'd like to admit. And I have a feeling that many of you who are listening also have had to go through this. So before I go further, I just want to tell you guys a little bit about Montefiore briefly, just in case you're not aware. Montefiore Medical Center consists of 3 hospitals, Moses, Einstein, and Wakefield. We all have ICUs. Moses has the most, Einstein second, and Wakefield has just the 1 ICU. And we all have consult services as well. And all of these different ICUs function in one system and one unit to help take care of the patients throughout all the different 3 hospitals. So we're constantly moving patients back and forth to accommodate the low number of ICU beds and the high acuity of our patients. We do a lot of airway management. We're very proud of this at our institution. We've previously published on this, and I will get into this further throughout the talk. But in the critical care service, between the airways we do inside of our ICUs and also on our outreach services, we do about 1,000 intubations a year. And then if you include the ER, there's also another 1,500 airways that they do each year as well. On the right is a picture of our outreach kit that the critical care consult fellow always carries throughout each of the 3 campuses. It includes a bunch of airway adjuncts, video laryngoscopy, cricothyroidotomy kit, medications needed for intubation are carried with the fellow, as well as an intraosseous kit. I'm happy to answer more questions about all that if you guys have any. I wanted to briefly mention our COVID experience, as it was very heavily weighed in airway management. Montefiore, I'm sure we all had our own COVID experiences that, built on our who we are as doctors, but also were quite negative in many ways. Montefiore and the doctors and patients there had a very dramatic experience. This is data that was published in Critical Care Explorations, showing you what the ICU bed capacity was on the left in the dotted line before the pandemic, and then at the peak, what the number of intubated patients with COVID were sometime in April. So we were both overwhelmed, but also very proud of the care we provided during that time. And this experience was further chronicled in a CBS News documentary that's available on YouTube called Bravery and Hope, that we're also very proud of, that features a lot of providers that were there during that time. Okay, so I'm going to pivot a little bit and talk to you guys about a learning health system, because that's going to be the context for what I'm going to tell you about with the PREOXI trial. So a learning health system, as per the AHRQ, which has probably the most succinct definition, is a system that takes clinical research or any research and then examines the evidence behind that research, applies it in practice, and then uses data, generally through electronic means, to then figure out if we're actually implementing the evidence that we're supposed to be, and then feeding it back to the bedside. So it creates this consistent feedback loop that informs our practice and helps us think about not just, do we know what the research is? Do we know what best practice is? But are we doing it? There was actually a learning health system conference at NYU this last month that I attended with some of my colleagues. And it was funny because all the different institutions that came to talk about their own learning health systems, University of Minnesota, University of Pennsylvania, everyone had their own feedback loop. Some people showed this AHRQ graphic, but many people showed the same kind of circular feedback loop. And each new speaker would say, this is my circle that I'm going to show. Everyone kind of had their own thing, but it all kind of said the same thing. It's not just evidence. So I'm going to break my talk up into this same format of the learning health system. So first I'm going to talk about evidence, and mostly through this, I'm going to tell you about the PREOXI trial. I'm going to talk about practice, and in practice, I'm going to talk to you a little bit about work we've done in the past at Montefiore to look further at our own intubation practice and outcomes, and how we figure out what we're actually doing, what we've done in the past, and how we're applying the PREOXI trial. And then I'll tell you a little bit about data, which in this context, I'm going to tell you about our own implementation project of the PREOXI trial results. So I'm going to give you guys a little bit of background for the PREOXI trial. So this is data from the Intube study, which we actually enrolled patients in prior to the pandemic here at Montefiore. Pretty much Intube, for you guys who are not aware, is an observational study from across the world looking at practice and outcomes for emergency endotracheal intubation. And the conclusions of this study is that intubation is in fact very dangerous, with many of us are well aware, with almost half of patients having a major adverse event. The predominant adverse events that happen are often cardiovascular instability, defined as you see in this graph, with need for increased vasopressors, low blood pressure, need for fluids, and other hypotension markers. But in addition to cardiovascular instability, severe hypoxemia happens in almost 10% of patients. And interestingly, when we've looked at our own data that I'll show you guys, at Montefiore, we also, in the past, prior to the pandemic, had a severe hypoxemia incidence of about the same, 9 to 10%. And then, of course, the worst outcome would be cardiac arrest peri-intubation. That's what we're all trying to avoid. So these markers that we have above are more common, the hypoxemia and hemodynamic issues. But of course, cardiac arrest is the thing that we really want to prevent in our patients. That's what we dread when we intubate people. So the issue is that cardiac arrest only happens in 3% of patients. And it kind of feels like it happens even less. In Montefiore, in prior data, we've shown that in about 4% of our patients, they die within 24 hours or so. So about the same number of our patients are dying during and after intubation. The problem is, even though you want to prevent cardiac arrest the most, it happens the least. And so doing a study in which you're using cardiac arrest as the primary outcome really isn't feasible. You'd have to enroll way too many patients, thousands of patients, in order to power the study appropriately. But luckily or unluckily, depending how you look at it, hypoxemia is an excellent surrogate marker for cardiac arrest, the primary thing that we want to prevent. So in prior data, it's been shown that hypoxemia is strongly associated with the incidence of cardiac arrest. So if we think about doing a study to prevent cardiac arrest during intubation, hypoxemia is a really valid surrogate marker. And how do we think about hypoxemia during intubation? So many of you guys are well familiar with this oxyhemoglobin dissociation curve, right? The whole idea is that when you're on the right side of the curve, it's pretty flat. And then once your PaO2 gets to a certain level, your oxygen saturation drops precipitously. So if we want to make intubation safer, what we'd probably want to do is start the intubation way on the right, where our PaO2 is much higher, and we have a lot more wiggle room before we get onto the vertical part of that curve, more vertical part, when intubation can become a lot more dangerous. So preoxygenation, what is it? It's pretty much a procedure that happens before you give anesthesia medications, whereby you're making the PaO2 as high as you can to get yourself on that flat part of the oxyhemoglobin dissociation curve. And what you're actually doing, for those of us who are pulmonary physiologists, like I'm sure many of you guys on the meeting are, is you're filling up your functional residual capacity with oxygen. Your FRC during intubation is kind of like an oxygen tank. So the more you could fill it up, the better your patient's going to be. And also the bigger you can make your FRC, probably the better off your patient's going to be, because more oxygen is going to equate to more safety being on that flat part of the oxyhemoglobin dissociation curve. So this is just a little more data from anesthesia literature looking at the impact of functional residual capacity on oxygenation. So in the left graph, what we see is pre-induction, what the functional residual capacity is, and how once you give anesthesia medication, the functional residual capacity of the patient drops precipitously. And then as you apply more PEEP, which this is invasive ventilation that is in this study, but we can also think that when we apply non-invasive ventilation, we're also giving something analogous to PEEP, right? We're giving that end expiratory positive pressure that's going to increase our functional residual capacity. And then you could see similar findings on the right when you see, as you apply more PEEP, first pre-induction, the patient's the PaFO to P to F ratio is adequate. Then you give the anesthesia medications, the P to F ratio drops precipitously. But then as you give more PEEP, just like the FRC is going up, so does the P to F ratio, so does the oxygenation. So we can see physiologically how that increase in FRC is positively impacting our patient's oxygenation. So given the physiological basis behind non-invasive ventilation use, the fact that we're able to increase our FRC, we're able to make our PaO2 a lot higher, of course, it would make a lot of sense to use it before intubation. So prior data, though, is really limited. There's one study that we see here that was done in France, published in 2006. And I very distinctly remember this study when I was a fellow, because I always thought about the interesting font that they use in their graphic. It's like kind of cute and like sticks out a little bit, but it was kind of strange to me for a Blue Journal article. But what we can clearly see, and we think provides good evidence when we, on first glance, look, is that patients who got non-invasive ventilation with the dashed line on the left, they don't desaturate as much, whereas patients that got conventional ventilation did desaturate during intubation. The thing with this, when you look back at this article, that's really interesting. There's only 26 patients in one group and 27 patients in the other group. So these same authors, the same study group, did a follow-up study looking at the same questions, non-invasive ventilation, and then subsequent impacts on organ failures. And the results were somewhat equivocal, although non-invasive at that point also decreased desaturation. At the same time, that study was only a couple hundred patients as well. So two very small studies showing that there might be benefits in non-invasive ventilation, but we're not really providing great evidence base for practice change. So due to the positive findings in those prior studies, when we look at previous guidelines, we see that there is some suggestion from societies that non-invasive ventilation should be used before intubation. This is the Difficult Airway Society, and they say to consider CPAP or NIV before intubation. But they don't say you definitely should use it if feasible and safe. So despite this recommendation, when the Intube study came out, we all documented what our preoxygenation method was, and most patients weren't getting non-invasive ventilation. Most patients were either getting bag valve mask ventilation before intubation or a standard face mask, which in most cases, I think throughout the world, is probably a non-rebreather mask. And then, so that's almost, or more than 75% of patients getting those two devices, with non-invasive ventilation being third at 11.6%. And then this question of high flow always comes up whenever we talk about the PREOXI trial and interpretation results. The best data we have is that high flow nasal cannula is only used in 5.4% of intubations, although this data was pre-pandemic. So the PREOXI trial study group hypothesized that preoxygenation with non-invasive ventilation will reduce the incidence of hypoxemia compared to preoxygenation with an oxygen mask. So for those of you not familiar with the PCCRG, it's a clinical trial network. It consists of 25 centers across the US. It's multidisciplinary in that ER people, anesthesia, and critical care medicine are all involved. And they have a long history of pragmatic, high-quality trials that I'm sure a lot of you guys are familiar with. You're looking at things like the effectiveness of bougie and fluid bolus and bag valve mask before intubation, which we can certainly talk about more in the context of the results that I'm going to show you. So this was the design: multi-center, parallel group, unblinded, pragmatic, randomized trial, comparing what I was just telling you guys about, non-invasive versus an oxygen mask, which is generally in practice a non-rebreather mask. The inclusion was all patients undergoing oral tracheal intubation using a laryngoscope and sedation. So no cardiac arrest, no awake, difficult intubations with a bronchoscope or anything like that. And the exclusions were if the patient was already receiving positive pressure ventilation, so if they're already on non-invasive, if the clinician determined that one would be better than the other, then they were not included. If the patient was apneic or hypopneic, and then these ethical, pregnant and prisoner characteristics. And of course, if the patient needed to be intubated more quickly than you could enroll the patient, then they were not included in the study, they're excluded. So at the bedside, when we do these studies, what happens is you have an opaque envelope, and then you have a checklist determining the patient in fact meets criteria for inclusion in the study. You open the opaque envelope, and out comes a group assignment. And the group assignment would look exactly like this if the patient was in the group randomized to non-invasive ventilation. So every patient was put on FiO2 100%, expiratory pressure of 5, and inspiratory pressure of 10, with a backup rate. And then all patients were preoxygenated, ideally for at least 3 minutes, and almost every patient was. In the supplementary appendix and the data analysis plan for this study was included this figure on the right that just tells us about the procedure of preoxygenation, the idea that we're giving non-invasive for preoxygenation, and then in almost every patient, non-invasive was left on after induction of anesthesia, and then taken off only when you're ready to insert the laryngoscope into the mouth. In very few patients, the non-invasive was removed and the patient was bagged. If you opened up your opaque envelope and the patient was randomized to face mask, this is what it looked like. You were asked to put the non-rebreather mask on the patient, turn the flow rate all the way up. Oftentimes we call that flush rate when you turn it all the way up and such that it's making a crazy noise. And you were asked to preoxygenate for greater than 3 minutes. You were allowed to use a BVM without bagging the patient. But I found this did become very confusing, especially if people weren't completely familiar with the trial protocol. And so I encourage people just to use the non-rebreather mask rather than hold the BVM over the patient without bagging. And then after induction, you were allowed to bag the patient, to squeeze the bag. The primary outcome was hypoxemia, a saturation less than 85% between induction and 2 minutes after intubation. So interestingly, what you might notice in the results is that the numbers are a little bit different in the actual rates of how many people became hypoxemic compared when you look at the PREOXI trial, the Intube study, and even the own internal Montefiore data. And the reason being is that hypoxemia was defined differently in the different studies. So an Intube is defined as less than 80%, whereas in the PREOXI trial it was less than 85%. So therefore, it's hard to say, like, initially when the trial results were presented in Belfast, one person said, oh, these patients were a different population than Intube. But in fact, it's because the primary outcome was defined differently. The secondary outcome was just the lowest saturation between induction and 2 minutes after. And these are our exploratory outcomes regarding oxygenation, cardiovascular outcomes, clinical, and aspiration. And I'll highlight the cardiovascular and aspiration. Those were the most interesting, I think, in interpretation of the trial results. So the study was published last June. I'm really proud to say that 6 Montefiore attendings were byline authors in this study, which we were really proud of. We're proud of our contribution and also that we had so many authors. So this is the flow diagram for the patients. At the end of the day, 1,301 patients were randomized into this study. We were really proud of the fact that at Montefiore, through the 3 campuses and 4 ICUs that participated, we enrolled 103 patients, which we were very proud of. And even though the trial was intended to be powered for 1,300 patients, they emailed out to stop the trial pretty late at night. And I didn't see the email until the next day. And we had an enrollment that was the 1,301st enrollment. And for that, the trial group organizers, including John Casey, who is from Kentucky, I believe, sent us a Kentucky Derby pie. And this is our research team, our coordinators and head coordinator, enjoying the Kentucky Derby pie from the coordinating center. So for those of you who have not yet seen the results of the PREOXI trial, this will be very exciting. This is the same slide that was presented by John Casey and Kevin Gibbs in Belfast when they presented the results. So have a drum roll in your head. And then the incidence of hypoxemia in the oxygen mask group was 18.5%. In the non-invasive ventilation group, the primary outcome was 9.1%. So absolute risk difference of 9.4%, which was a strongly positive result. And then also really interesting, this appears in the supplementary appendix. No matter how you define hypoxemia, whether it was that outcome of 85%, 80%, or 70% that were pre-specified in the data analysis plan, the application of non-invasive ventilation cut hypoxemia in half, which is a really dramatic and interesting finding. So if we look at the number needed to treat, we take 1 over the absolute risk reduction, which was 9.4%, and we get a number needed to treat of 10.6, which will round up to 11. So this is really impressive. Just thinking about other interventions that we do in critical care that we, of course, accept as really helpful for patients, like lung protective ventilation, which has a number needed to treat of 10, and aspirin, which has a number needed to treat of 42. The fact that number needed to treat is between 10 and 11 for the PREOXI trial for the application of non-invasive ventilation to prevent hypoxemia is really impressive. I understand that we're talking a little bit about apples and oranges and that lung protective ventilation is lives saved versus PREOXI. The primary outcome, remember, is I think is somewhere in between disease-oriented and patient-oriented outcome, the percentage of hypoxemia, but I think still very impressive results to have a number needed to treat for what is essentially a pretty cost-effective and safe procedure, which we could talk about further. This is the forest plot that's in the study, and it has a lot of really interesting findings. What you guys could see is that overall, non-invasive ventilation was certainly better, as outlined by the absolute risk difference at the bottom. In the ER, in the emergency room, the confidence interval crossed over. However, there were less patients. About a quarter of the patients were enrolled in the ER, so the sample size was lower. What you guys could see that's really interesting is that non-invasive ventilation was more impactful in patients that had non-invasive, that had acute respiratory failure But at the same time, even for patients without acute hypoxemic respiratory failure, non-invasive ventilation was still superior than oxygen mask alone. And if you go down to the bottom, you guys could see the FiO2 in the previous hour. And this is along the same lines as what I just told you about acute hypoxemic respiratory failure. What you could see is actually what looks like a dose-response relationship, where the more hypoxemic you are, the more positive impact you'll have from non-invasive ventilation. At the same time, even patients who are on room air prior to intubation still benefited from non-invasive ventilation. So when you go and implement the PREOXI trial findings at the bedside in your own patients, it's really important to remember that there's no group that we were able to identify that did not benefit from non-invasive ventilation. Because you might have people that say, oh, they don't need non-invasive ventilation, they're on room air, they don't have hypoxemic respiratory failure, their PDAF ratio is good. It actually is not true based on the PREOXI trial results, that it's possible that every patient who meets the inclusion criteria for the PREOXI trial and doesn't have obvious dangerous reasons not to get non-invasive will benefit from non-invasive. So really remember this forest plot and the findings in it. Another really interesting thing is the body mass index findings, which goes back a little bit to what we were talking about with the physiology of functional residual capacity in reference to preoxygenation. So even though patients who are non-obese is defined by BMI less than 30, even though they also benefit from non-invasive ventilation, what you guys could see is that patients who had BMI greater than 30 had a much more dramatic impact of application of non-invasive ventilation. And there is, just so you guys are aware, and if you're interested in the supplementary appendix to the PREOXI trial, there's a lot more graphs that look and charts that look at the interactions of all these different factors in graphical ways to kind of describe how what we've just been talking about for the last minute or so looks on in graphical form. I encourage anyone to go check that out. So just thinking a little bit more about what I mentioned before about cardiovascular outcomes, the most interesting finding was that even though this study is of course not powered to look at cardiac arrest, you'd have to enroll thousands and thousands of patients. In the oxygen mask group, there were 7 cardiac arrests, and non-invasive ventilation, there was 1 cardiac arrest. So this was a pre-specified primary outcome, and it was significantly different statistically, and we think clinically. In the supplementary appendix, there's a somewhat busy table that I think is important, though, that tells us each of the cardiac arrests that happened during the trial and the clinical context. And what you guys could see, if you look at lowest SpO2, is just that a lot of these cardiac arrests, we're in the context of either low oxygen saturation or inadequate plethysmography, which can happen in the context of shock, but that we can make a case that a lot of these arrests occurred because of oxygen, because of inadequate oxygenation of the patient. And that the 7 that happened in the control group might have been mitigated with application of non-invasive ventilation. Further interesting findings was just in the group that was enrolled in the PREOXI trial, and keeping in mind that there were a bunch of patients that were excluded because clinicians felt their non-invasive would be dangerous due to risk of aspiration. In the group that was included in the PREOXI trial, oxygen mask group had slightly higher operator-reported aspiration events than the non-invasive ventilation group, which was, of course, not clinically significant. Oh, not statistically significant. So the limitations, which it's unclear how many of these are in fact limitations. We excluded patients that are already on non-invasive ventilation, but the argument could certainly be those patients already benefiting from non-invasive ventilation and might have even diluted out the actual positive impact of the trial. So if anything, perhaps inclusion of those patients would have helped the findings favor non-invasive ventilation in the end. We excluded patients with emesis and hematemesis, so we have to be careful about application of non-invasive ventilation in that patient population. This is an open label trial. We, of course, knew the group assignments. And then there's a question about high flow nasal cannula that we can address because this always comes up whenever we talk about the PREOXI trial results. So just a little bit more about high flow nasal cannula. The things I want you to keep in mind when the question comes up about, oh, I like to use high flow nasal cannula during intubation, I put it on for preoxygenation, and then of course I can use it during intubation for apneic oxygenation, which is on the surface a valid point. However, the things to keep in mind regarding this conclusion and idea is that in the intube study, only a very small proportion of patients were actually getting high flow nasal cannula for apneic for preoxygenation. So this doesn't address the major reason or the major ways that people get preoxygenated in practice. Furthermore, we can look back at the Florali 2 trial. You guys may remember the Florali 1 trial that looked at high flow nasal cannula versus non-invasive to prevent need for intubation. This was the Florali 2 trial that was actually published right before the COVID pandemic, and so might have gotten buried a little bit, but actually enrolled a somewhat smaller number of patients, about 400 patients, and looked specifically at this question of what's better for preoxygenation to prevent desaturation, high flow nasal cannula or non-invasive ventilation. And although the study was statistically did not find difference between the two, the point estimate in the main study question showed that non-invasive ventilation was superior. And then when they looked at the pre-specified group of patients with P/F ratio less than 200, they actually did find that there's a statistically significant improvement in desaturation in the patients that got non-invasive compared to high flow. Therefore, from my perspective, this question has already somewhat been answered in a smaller study. And we can feel comfortable that we shouldn't be withholding non-invasive ventilation because we feel like high flow might offer patients more. Is there any questions about the high flow nasal cannula versus non-invasive ventilation? Okay. So in summary, the PREOXI trial enrolled 1,301 patients. We found that non-invasive ventilation reduced hypoxemia from 18.5 to 9.1%, with a number needed to treat of about 10. Cardiac arrests were significantly different between the groups, and the aspiration increased in the non-invasive ventilation group. So then we think a little bit more about how this could impact my own home institution. So we do about 2,500 intubations a year between the critical care service and the emergency department. And when we've looked at our own data, about 10% of these patients, which is pretty close to what happens in what happened in the intube study, experience desaturation. Therefore, we might be able to prevent hypoxemia in 26 patients. And if about 4% of our patients get cardiac arrest peri-intubation, we might actually be able to prevent cardiac arrest in about 10 patients by applying non-invasive ventilation. Okay, so for the rest of the talk, I'll shift a little bit to practice and data, unless you guys have any questions about the PREOXI trial in particular. Okay. So going back to the idea of a learning health system, I talked to you guys about research and evidence. We have that now with the PREOXI trial. We know that non-invasive ventilation before intubation can prevent hypoxemia and possibly prevent cardiac arrest and save lives. But then how do we implement that in practice? So the HRQ says that learning health systems capture and analyze data and care experiences to improve care. They continually assess outcomes, refine processes and training to create a feedback cycle for learning and improvement. And this is a lot of what I was telling you guys about before. So this is a figure that I really like from a clinical research book that I've had for a while. And it talks about some of the same ideas that we think about in a learning health system. So if we start on the top right, we have the findings in the study. And we know that in the PREOXI trial, non-invasive ventilation reduces hypoxemia. And then we try and determine in a journal club format or in our own brains, just thinking about it, whether this is really true, this is really a good study and that if the conclusions are valid. And then we think about if this study would have been done anywhere with any patient population, if this is really true. And then we bring it back again and think about, okay, well, if the study really showed that, can we show that in our own practice at the bedside on an ongoing basis that non-invasive ventilation is really going to prevent hypoxemia? So we have the findings in the study, and then we try and extrapolate that outward into our practice, kind of the same idea as a learning health system. So what I want to introduce to you guys a little bit is this idea of how we actually learn about our own practice of intubation and how we get data. And the way I've always really liked thinking about this is that the best way to do this is through a really good intubation documentation note. And this is somewhat of my life's work, this, or at least professionally, this intubation note. Ever since I came to Montefiore, we've had 2 different iterations of that note that I've spearheaded and made a lot of changes to compared to what it was 10 years ago. And I'm really proud of the current note, and it's driven a lot of our research and also what we know a lot about after the PREOXI trial publication. So this is our note. It's fields that is what's called a smart text. And each intubation attempt has its own data that is checked by the intubation operator. And then there's specific yes, no columns regarding complications of intubation. Particularly, you guys could see at the bottom, saturation dropped to 80%, which is applicable for what we're talking about. We've already done a lot of research using this intubation note that I'm really proud of. And we've learned a lot about our practice and outcomes. And we've also just answered very basic questions. Like, I'm proud to tell you guys, we do 1,000 intubations a year in the critical care service. That's not something we'd ever would have known without being able to capture data from the note and then extract that data and analyze it. So we've looked at our own practices with regard to video laryngoscopy, muscle relaxants, and then, what is our data in the daytime versus nighttime? What is our data inside the ICU, outside the ICU? And we've had a bunch of interesting findings and learned really a lot about our own airway practice. So when I got to Montefiore, the critical care service is very proud of their airway management, as they should be. But we didn't really know much about these things. And now we have a really good idea of who we are, what we do, and how we've changed over time. This is data that I'm really proud of that we published in the context of the pandemic. We looked at 782 pre-pandemic intubations, and then we looked at the peak of the pandemic and the 2 or 3 months after the pandemic, the onset of the pandemic. And we looked at pre and post how things change. And of course, we started using a lot more video laryngoscopy and neuromuscular blockade in keeping with concerns over infection control. Patients had a lot higher risk of desaturation in the context of severe RDS. But interestingly, our first pass success rates went up a lot, likely in the setting of increased use of DL and muscle relaxants. This is data that I looked at in 2023 before we started enrolling or right after we started enrolling in the PREOXI trial. And Tom asked me earlier to think a little bit about how much we're actually using non-invasive ventilation. And I'll show you guys a little bit more granular data. What you guys could see in 2019, we used it about 12, 13% of the time. And then once the pandemic started, the rates dropped because, of course, everyone was worried about infection control in the context of spreading COVID to providers and other patients. So the rates dropped and then it went up again. And then we started enrolling in PREOXI and it went up a slight amount, keeping in mind that we only enrolled 103 patients in the trial. So it couldn't have made too big of an impact. And then likewise in blue, the blue bars represent hypoxemia. So what you guys could see is our rates are about 10%, just like the Intube study. And then they went up precipitously with the pandemic, and then has since dropped to some extent. And what we want to see over time is with increased use of non-invasive ventilation, will we be able to reduce the incidence of hypoxemia peri-intubation? So we've thought a lot in the PCCRG about how once we have an interesting research finding, how can we implement it in practice? You guys have all heard over and over again, probably throughout your medical careers, about how long it takes for actual data to be implemented in practice. And what we're trying to think about is how to do a better job with this. So Kevin Seitz, Sue Stenbeck, and Jessica Alexshapa from Vanderbilt, Leahy, and Wake Forest. And we've been meeting, first we were meeting once a month, and now we meet every 3 or 4 months to talk about ideas regarding implementation. So one thing we've been thinking about is a common barrier that people talk about is the idea that, okay, non-invasive ventilation is great, but if you have to get a whole other machine to give non-invasive ventilation, that's going to present a significant barrier to it actually happening at the bedside. But what we actually did was we assigned a couple Montefiore house staff, NIG Brisbane and Gerardo Rahman, as a resident and fellow at Montefiore, and I had them go and look for all the patients, all the sites that were enrolling in the PREOXI trial. They looked at each ventilator, invasive ventilator, and they were able to find that at least either with the base software or with an upgrade, you're able to apply non-invasive ventilation through the actual invasive ventilator. Therefore, what you can do, and what we did at Montefiore, is you almost always went and got the invasive ventilator, and you gave non-invasive ventilation before intubation through the invasive ventilator, and then you switched to invasive mode once the patient was intubated. And their work was subsequently turned into web-based information and is now available on the PCCRG website on the through the PREOXI trial page. So this is a run chart looking at non-invasive ventilation use and hypoxemia by month at Montefiore. And this is our baseline data. So each month, you guys could see non-invasive ventilation use changing, and the median in the red line is 15%. So that's what we were doing before the PREOXI trial publication. And then the dashed line, which is in blue, is the incidence of hypoxemia. So if we look at this continually over time, what we want to see is that the light blue line goes up, our non-invasive use goes up, we're applying the PREOXI trial results, and that the blue line ideally goes down. So in thinking about how better to apply non-invasive ventilation at the bedside, we put together a Ishikawa diagram, which is a cause and effect diagram, which is pretty much a brainstorming tool. To help us think about where we should put our efforts regarding making sure that non-invasive ventilation happens. And we thought about barriers to applying non-invasive ventilation. They might be the patient might be claustrophobic, they might have a high risk of aspiration. There might be equipment issues, like that, in fact, your invasive ventilator doesn't administer non-invasive. There might be system problems like lack of protocolization. There might be issues with the intubation operator or critical care team, like that they don't know about the PREOXI trial results or they forgot. And there's often issues with respiratory therapy. Maybe they don't know about the trial results and put up some sort of pushback regarding application of non-invasive, or maybe they just didn't bring the mask or they didn't bring the ventilator yet. And what was brought up in our implementation working group is that oftentimes there's issues with team dynamics, where maybe a fellow is aware of the PREOXI trial results, and maybe the respiratory therapist is as well, but maybe the attending is not comfortable applying non-invasive ventilation because either they don't believe in the results, or they're not aware of them, or they feel like the patient is too high risk for another reason. So we use at Montefiore the IHI process improvement model. So this is our key driver diagram that we made to think about how to implement non-invasive ventilation. We made a SMART aim, which you guys are probably familiar with and can apply to anything in life. The SMART aim for this particular project is increasing non-invasive use from 15% previously last year to above 30% by the end of this calendar year. And our key drivers that we wanted to think about were standardization across our system, equipment availability, and education. And you guys could see our change concepts just fed into those key drivers. Things like non-invasive guideline, respiratory therapy, bringing masks to every intubation, and then lectures. Our overall goal, of course, was to increase the number of patients that got non-invasive, reduce the risk of hypoxemia, and ultimately reduce cardiac arrest. And then whenever you do something like this, you have to think about balancing measures. So we want to think about aspiration events, which we track through our intubation note, and non-invasive mask cost and waste, which interestingly was brought up in a New England Journal letter after the PREOXI trial, concern regarding the environmental impact of more masks. So we don't yet have that data, but we're able to get it from the supplier, and I'm told that I'm getting it any day. So this is just an ongoing run chart before I showed you guys up through PREOXI trial publication. And you guys can see when we annotate the run chart, what kind of impact different interventions might have had. So that I presented the results to critical care in May, and the trial was published. We saw a little bit of a jump in use, and then things kind of went back to business as usual, or even below that. And then I'd like to think that in October, as part of a fellowship visiting applicant talk I gave to both pulmonary and critical care divisions regarding the PREOXI trial results, that we had a big jump in non-invasive ventilation use. Other interventions I subsequently did, then in November, I put non-invasive ventilation masks because we found that mask availability was a big barrier. Everyone kind of knew about the PREOXI trial because we did the trial and because I was going around yelling about it for months. But people are saying, well, I don't have the mask. So what we did is put the masks in our airway carts. And at least at the ICU that I'm the director of, I put the masks with a labeled amount of PAR into the same drawer that our video laryngoscopy supplies are in, which is something that we use almost every intubation. We also put them into the airway bag that the fellows carry. We still do this at the Wakefield campus, but there has been some pushback at other campuses regarding fellows feeling that there's too much stuff in the bag's too heavy, etc. So, the scaling of this process, I'll admit, has been a little bit rocky, although I do think it's helped to some degree when it happens. In order to make people more comfortable with the idea of applying non-invasive ventilation, if they haven't read the study or the study protocol, we made a Montefiore specific guideline for application of non-invasive ventilation for preoxygenation and posted it on our intranet site that is readily available to anyone in the hospital. Then what might have the biggest impact, in February of this year, we implemented at 2 of our hospitals for respiratory therapists to bring the non-invasive ventilation masks to the bedside when they bring a ventilator to every intubation. So this is Sammy, one of the respiratory therapists at Montefiore Wakefield, on his way to an intubation, bringing the non-invasive mask with him as well. I was very happy. I did not put up this sign. One of our respiratory directors put it up regarding communicating to her team of respiratory therapists that they were to bring non-invasive masks to every intubation. And then this is the most updated data I have. I'm trying to do the data every 3 months to see how we're doing. But what you guys could see, I'm hoping with that climb there, and it's not what we define as a true trend when we think about quality improvement, but it's close for our purposes, that in the past 3 months, we've had consistent increases in non-invasive ventilation use, and we're getting pretty close to our goal of 30% by the end of 2025. You guys can see the line on the bottom of hypoxemia hasn't really changed much, but we're hoping that we already know about the randomized trial data that non-invasive is effective. So if we're just applying non-invasive itself, we have a good feeling that we're impacting patients positively, and that maybe there's other external trends like it being a rough winter that impact hypoxemia, and that at least if we're applying non-invasive to patients, we're giving them the best chance they have to have a good outcome peri-intubation. So the next steps that I'm hoping for is building a Pareto diagram. So for you guys may not be familiar with the Pareto principle, but it's just the idea that the things that happen 20% of the time likely account for 80% of the outcomes. So with all those different factors I showed you guys in the Ishikawa diagram, we want to see how many of those factors really impact how often non-invasive ventilation is or is not applied at the bedside. And what we want to try and do is see how much our key drivers, each of our key drivers, are changing over time. what we've been thinking about doing is using a program called Elastex that uses natural language processing to identify anything in the medical record, including intubation notes. We want to figure out how often not only is non-invasive being applied, but then we want to give feedback to intubation providers themselves who might not have used non-invasive ventilation. So this is an example of Elastics and how you'd use it to find all the intubation notes that happen during a certain period of time. So these are all the intubation notes that happen in February, just one screen at a time, 10 of those. And then what we do is we look for what notes have the phrasing preoxygenation used prior to first attempt, which is very specific to our own internal intubation note. Then we could look and see for this particular note, and I hate to call out Dr. Redner, who's actually enrolled the most patients in the PREOXI trial of anyone at Montefiore. For this particular patient and intubation, he utilized nasal cannula for preoxygenation. So what the idea is to reach out to Dr. Redner or anyone else who might not have used preoxygenation and poll them regarding why they didn't use non-invasive ventilation. And through that, hopefully target our change concepts or the things that we're going to do to hopefully influence our key drivers, which remember were standardization and education. We haven't actually figured out how to get this going in practice. It requires a little bit of a lift. I've tried assigning fellows to this quality improvement initiative, and it hasn't totally taken off. So another way I've tried to give feedback, just on a more global level, is the run chart I showed you guys before. I actually started, whenever I do a new run chart, I email it out to all the critical care, pulmonary and critical care teams, so like 150 people, and I give them feedback with how overall we're doing as a team, rather than on an intubation to intubation basis. And I'm hoping that that keeps the PREOXI trial results and the goals of non-invasive ventilation up to 30% by the end of the year in their minds, so that they have actual feedback regarding how we're doing as a team. So this is an alternative case. The same patient you decide to intubate, the respiratory therapist brings a ventilator as well as non-invasive that will interface with the ventilator. Non-invasive is applied, just like in the PREOXI trial, at 100% FiO2, EPAP of 5, IPAP of 10, and you give it for 3 minutes, which is the standard of care. Oxygen saturation increases to 100%. You give the intubation medications, and you get first attempt success. And oxygen saturation does not drop below 97% from the time that induction is given to 2 minutes after. You are so thankful you found out about the PREOXI trial study and that you work in a learning health system. So key points. The PREOXI trial demonstrated that non-invasive ventilation can reduce the risk of hypoxemia and potentially prevent cardiac arrest. The intubation note itself is a powerful tool to examine practice and outcomes of emergency endotracheal intubation. Montefiore's commitment as a learning health system puts us in an excellent position to examine the evidence of the PREOXI trial, change our practice, and continually get feedback to determine the impact that we're having on patients. Thanks so much, guys, for your time. This is just a list on the left of the top enrollers in the PREOXI trial. Give credit again to Dr. Redner, who enrolled 13 patients, and a bunch of our fellows. You can see the top fellow enrollers, and they were all listed in the supplement and are indexed on PubMed with this study as well, which is really cool. Thank you so much for your time, and I'd be happy to take any questions.
Thanks, Dan. Very cool presentation. Let's see, any questions from folks?
Yeah, do you want to go? Go ahead.
Kevin, did you have a question?
I did. Dan, that was absolutely fantastic. I really enjoyed it.
Thank you.
When I think of learning health systems, I think of platforms. I think of a lot of feedback and such. And one thing I wanted to ask you is, maybe I missed it, is the fellow and the learner feedback on the learning health system. You talked. I really loved your data and the outcomes, and I watched it go from 15 to 30%. But what about the feedback from the learners back to the organizers or to you and your colleagues that are really setting the learning system up, because you know, you can have a learning health system and you're showing us results, but that is an important part of the like you were talking about, the feedback. How do you gather that and how do you adjust it?
Do you mean in terms of non-invasive ventilation, or you mean just kind of globally?
And globally, I mean, your
Right.
focus on, I just am specifically asking about the learner feedback and how do you incorporate it specifically?
Right. It's a really good question. I think we're still struggling a little bit how to set up this idea in a broad sense. At the conference I went to at NYU, a bunch of other institutions, as I mentioned, had really outlined frameworks for this concept. But here at Montefiore, we're still working on it. We have a few proposals to administration in the near future, but we have to think more about the learner, as you said, is really the person who's going to impact and apply the results at the bedside. But I don't have a great answer for you. I'm sorry.
Yeah, and another issue, because these learning health systems are so local, is like you were mentioning the different campuses. How do you, I mean, you're going to do it. I don't have any because you were able to pull off this large multi-center trial and get everyone doing the same thing, and that's part of this learning health system. But and then and sustainability over time is another issue that the learning health system will help develop, correct? And so I agree. I just think this is a great project, and I know you'll solve that with the feedback and the learners too. Thank you.
Yeah, thank you. I think one way that is certainly used frequently that the group at NYU and others do is through the electronic medical record. They try to communicate with people on what they're doing, how they're doing, or even randomizing, doing this, getting the information itself, randomizing specific patients to certain interventions, and then communicating with the learner through that. So it might be a different type of fluid that one patient gets or another. It might be a different type of follow-up that the patient gets after discharge. But at the same time, there's also a lot of acknowledgement that communicating only through the medical record is very onerous to providers, that constant communication is felt to be an impediment to their own patient care. So that's something I think we're certainly going to struggle with as we scale this further in the near future here.
Thanks, Dan. Appreciate you giving this talk. I think really gives us something to think about in terms of our own practice here.
Yeah, thanks a lot.